welcome to ACLS Module 1, Cardiovascular Care. I'm pleased to have Dr. Mike Wilson here from Providence St. Vincent's. He's an interventional cardiologist, and he's here to talk a little bit today about cardiovascular disease and STEMI care. And so without further ado, I'm going to step out of the camera and I'll be asking questions and kind of leading the conversation to get started here and let Dr. Wilson teach you all that he knows. All right, so without further ado, we start with just some basics about cardiovascular care. Just the definition of heart disease. You know, you hear a couple different terms: coronary artery disease, coronary heart disease. Are they the same?
Sure.
Just
well, first of all, I'd like to thank you for inviting me to do this teaching module, and I'm pleased to be here with my partner Adrienne, who has worked with the STEMI program here in the Portland area for many years now, and I've been director here for over a couple of decades. And but I also handle other types of cardiovascular management, and so I feel comfortable kind of presenting some basic concepts of cardiac disease. I found it's helpful to break things down a bit. So when you think about the heart, which is, of course, the most amazing organ in the body, I like to think
no bias there.
No bias. We can break things down in anatomy. We can look at if we break that down into chambers, ventricular or muscular function, and if we look at valves, pericardium, and aorta. So just thinking simply along the anatomy, and often what comes to mind is an echocardiogram that would show these things. And when I draw a picture for a patient, for example, I might draw a picture of the left ventricle and the aortic valve here, the aorta, and a mitral valve and a left atrium. So in certain views, we would look at left ventricular function, a left atrial size, in this view, mitral valve, aortic valve, and aorta. So if you break it down into these concepts for anatomy, that's a good start. But
do you pay attention to the right side of the heart, or is it all the left side? We'll get there. Okay.
I'll get there. Before I jump into some of those details, so also think about the electrical part of the heart, of course. So heart rhythm. And then, of course, pertaining to STEMI, we have very specific electrical findings on an electrocardiogram that can diagnose, STEMI, and other anatomic variants can be detected even through the electrical system to give you a sense of what you might find as you move on. And if we look at the physiology then, and here we think about heart failure for one, and we think about pressures inside the various chambers. We think about valvular regurgitation, how this may affect cardiac output, the amount of blood that can be delivered from the heart to the various organs. So breaking it down into anatomy, electrical, physiology, this is an important way to help simplify matters. But let me go back and talk about the kind of chambers of the heart and what we think about there. So there are different ways to draw the heart. I'll start with this here. So if we draw a four-chambered heart, we have right atrium, right ventricle, left atrium, left ventricle. We have, this is the entire left ventricular chamber here, and this is the septum of the heart. And this is the atrial septum, this is the ventricular septum. So we know that inflow, if I draw this blue, so blood that has been, where oxygen has been used up, and so our venous blood will come up here through the inferior vena cava and enter the right atrium from the superior vena cava, come down this way and dump to the right atrium. This deoxygenated blood will mix here and then cross the right ventricle, and if I change the angle a bit, so here's the right atrium, and show the outflow of the right heart. So if we look, I've taken out the left ventricle here, and so this blood from the right atrium crosses the tricuspid valve and then moves out the right ventricular outflow tract, RVOT for short. So the blood will be ejected across the pulmonic valve here into the pulmonary artery. So this is the main pulmonary artery, left and right pulmonary arteries, and go to the lungs to be oxygenated. So in the scenario that one thinks about when you think about the right heart and disturbances of the right heart, you can imagine if one had a leaky tricuspid valve, say you had a dilated or enlarged or dysfunctional right ventricle, you had a leaky tricuspid valve, that makes blood flow backwards here, which causes the atrial chamber to enlarge, and it causes back pressure into the liver, down through the inferior vena cava and up into the neck, where we can see neck veins that are largely pulsating because of tricuspid regurgitation. So the different pathologies happen here. If you have a stenotic or narrowed pulmonic valve, that can cause backup of pressure. So anything that causes backup of pressure will then be reflected in the physical exam in the venous system. If someone in acute disease, if you have a pulmonary embolism, so if you have a big clot that comes up from the leg and enters the right heart and floats out here, you can have a thrombus that can include either a life-threatening thrombus in the main pulmonary artery, or more commonly, some of these clots can make their way out into the periphery, and so that would be acute pulmonary embolism and how that might present. So if we just think about the right heart that way. Now, other things can happen. Disease processes can happen when we, if there's a hole in the atrial septum here, atrial septal defect or patent foramen ovale, there can be a crossing of blood on both sides. And more rarely, you can see this happening in the ventricle, either through congenital heart disease, but I'll leave that aside. But anyway, that's the blood flow into the right heart and out to the pulmonary circulation.
When you talk about that right side, would a disease process like COPD, where you would get, I would assume, correct me if I'm wrong, pulmonary hypertension?
Correct.
Would that also lead to strain on that right ventricle?
Exactly. So if you have lung disease of any kind, whether it's chronic obstructive lung disease due to cigarette smoking, interstitial lung disease, or other pulmonary pathology, what happens is there's more resistance to the blood flow moving through the lungs. Consider the lungs like a filter. So if that filter is clogged or not working properly, the blood can't get through it, and that causes backup of pressure in the pulmonary arteries. And that almost always is transmitted into the right heart. So we see an increase in right ventricular systolic pressure, and depending on the competence of the valve, we'll see an increase in the right atrial pressure. And we have ways to assess this, of course, when we do heart catheterizations. What's called a right heart cath is actually a procedure where we pass a tube in the right internal jugular vein, for example, and we have a balloon tip catheter that floats down through the circulation, out the pulmonary artery, out here, so we can measure the actual pressure chambers, the pressure in each of the chambers. And that condition you refer to is called cor pulmonale,
okay.
Which means heart disease due to lung disease. And so sometimes you might see someone who looks like they have a right heart failure with swelling, with an enlarged liver, neck veins are engorged, and yet their left heart circulation is okay. It's really that they're bad lungs that are causing trouble.
And for my critical care folks, that would be a Swan-Ganz catheter.
Yeah, so the name for that catheter is called a Swan-Ganz. We also, with this, it has multiple ports, so we can use it to infuse medications. We can do what's called thermodilution cardiac outputs, where we inject 10 cc's of saline through the catheter, and then a computer will estimate how fast that gets to the tip of the catheter, and it can, through its formula, it can calculate what the cardiac output and cardiac index is. So a lot of information. Also, in this, since we're on Swan-Ganz catheter, my picture's getting confusing, but if we move that catheter all the way out here, where the balloon tip hits the kind of as far as it will go, and remember this tube has a lumen in it, so we use a pressure transducer, and we can measure these pressures. And when you use the balloon to occlude the pulmonary artery tip, you're actually indirectly measuring the left atrial pressure. So we get more information just right atrial. We can assess the left side of pressure, which can give us more information about how the left heart is behaving. Let me erase this because it's going to get too confusing, and I can always start fresh. Any questions, or which way would you like me to
No, this is good. We got right into some critical care components.
Yeah. I jumped right to the basics,
which is
to,
great. I appreciate that. I guess maybe back out a little bit and explain a little about the correlation between the electrical side of the heart, the mechanical side, and what we may start seeing present in ST elevation, depression, things like that.
Yeah, sure. So first let me, if I can touch on the coronary anatomy initially to get a sense of things.
Sure.
So again, this is the aorta, this is the heart, and so it's important basic stuff to know that the coronary arteries arise from the coronary sinuses of the aorta. So the right coronary artery, for example, will come down here, or the bottom of the heart, and then each of these arteries will supply branches that are named when we describe cath reports. On the left side, we have this artery, and I want to describe these names a bit because they're really important. And it's important to think about the location of these blood vessels in relation to the EKG and the way the EKG findings will help us diagnose heart disease. So we're looking at a patient like this. This is the right coronary artery. This is the left main artery, so the trunk of the left coronary artery. This here is the LAD, or left anterior descending artery. This here is the circumflex artery. So when we think of inferior, we're talking about the bottom of the heart. So we're talking about here. If we think about anterior, a heart like this, we're talking about the front of the heart here, where that LAD is placed. So the LAD is a critical artery. So anterior, this part of the heart here would be labeled the apex. And then posteriorly, the circumflex vessel wraps around the heart and will show, will affect a part of the heart that's a little more difficult to sort out by EKG. But if, when we think of the kind of chest here, and we have our EKG leads, so the head's up here, and chest and abdomen. So, and we have limb leads on the arms and on the legs. it's important to just think in terms of 3 dimensions, what these leads are looking at. So consider these, each of these leads are looking at a certain part of the heart. So when we look at the limb leads, that's 1, 2, 3, A, B, R, L, F. We're actually looking at, for example, 2, 3, and F are looking at this part of the heart, the inferior leads. And after I get rid of this, I'll draw an EKG and show an EKG what we're talking about. But 2, 3, and F are looking at the bottom of the heart. These frontal leads are precordial leads. They're called the precordial leads. These look at the front of the heart, the anterior area. So they're looking at this area here. And it's only through indirect measurements that we can assess the posterior. But the way to think about the posterior leads is to you could just even take an EKG and flip it upside down and hold up to the light. And it's almost like you're looking at the bottom of the heart. So posterior is a little bit more difficult to sort out. So in the apex, when you see the apex here, it's important to know that apical heart attacks can happen because of different types of anatomic variation. So although most commonly a heart attack in the apex involves the anterior descending artery, the LAD artery, you can have a big right artery that comes around and covers the apex here, as you can have a big circumflex artery to cover the apex. Or it may be that the patient could have multiple artery disease and show up in the apex. So having done that, let me just draw some EKG samples here to tie this together a little bit. So just to review EKGs, we have the electrical part. So if this is a QRS complex, we have the atrial activity, also we call the P wave. We have the ventricular activity here, which is called the QRS. And then we have the kind of repolarization deflections on the tracing called the T waves. So the ST segment would be this segment between the QRS and the beginning of the T wave. So that's very important in STEMI diagnosis. So we're always taught in cardiology, in fact the French phrase is chercher la P, I guess. Always look for the P wave to try to identify what the rhythm is. So if you have a rhythm like this, narrow complex, no P wave, you might say, okay, that might be a junctional rhythm. If you see nothing there and then you see a wide complex, that could be a ventricular escape complex with no P wave. Or if we see this kind of pattern, so this can be atrial flutter, where you have a repetitive sawtooth pattern to the atrium. So when you're looking at EKGs, one of the first things to do is not get distracted by whatever else is happening, but first lay eyes on the P wave, and so you can assess the heart rhythm. Atrial fibrillation, on the other hand, is coarser, more, and tends to be associated with more irregular rhythm. Flutter can be a repetitive, regular rhythm when you feel a pulse, but when you look at the atrial activity on the EKG, you can see this pattern. So starting with that P wave. And then the QRS, we typically talk about narrow versus widened. So I like to go back to this heart model for a second. And if we think about how the impulse starts, we think about the sinoatrial node. These various nodes, think of them like telephone poles. So and the impulse starts at these various places of specialized conduction tissue. We have the AV node here. We have these bundles. So there's a left and a right bundle. Think of like cables or wires, and then the left we have an anterior and a posterior bundle. So there's a left bundle, right bundle, AV node. So an impulse starts here. It originates from the SA node. It moves down to the AV node during this period of time. which is normally under 200 milliseconds. And then it starts depolarizing the ventricle, and a normal conduction will be a narrow complex here as it spreads through the ventricle. If we have delay in conduction due to disease, either right bundle or left bundle, there'll be specific waveforms on the EKG, which you can see in your textbook or whatever, that will help you decide whether it's right bundle or left bundle branch block. And it becomes important in STEMI care because left bundle branch block can mimic or confuse the diagnosis of STEMI. So it can hide, it can cover up an underlying STEMI, and but we can still sometimes make a diagnosis of STEMI with left bundle branch in place. And sometimes we have to look at old EKGs to see if it was pre-existing or new. A brand new left bundle in response to a heart attack usually implies a fairly major heart attack involving this septum, so the conduction gets disturbed. But getting back now to STEMI, when we see damage to a heart muscle here, and your EKG is detecting this, you will see a rise in the ST segment. So that can go up like this, and so that's your hallmark. So when we look at the ST elevation, there are some specific definitions based on whether or not we're looking at the limb leads or the...
This is a surge activation for coverage. This
surge
is
activation.
A surge activation for coverage.
Anyway, we will, depending on how you want me to get into STEMI care, I don't know if it's the right time to get into STEMI EKG.
Sure.
But ST elevation is the key. ST depression usually means ischemia. It means there's not enough blood flow, but it does not mean injury. And so we differentiate ischemia from injury based on the EKG. And the specific patterns, like I said, with inferior, we will look at 2, 3, and F. Anterior, we look at the precordial leads. And lateral, which is the side of the heart, diagonals or circumflex branches. Then we can look at 1, L, B, 4, 5, 6. These are the leads. So there are specific electrocardiogram leads that correspond to the anatomic location of infarct.
Okay. Does let's see, augmented leads, the right side, mean anything to you? Or V1? Do you pay attention to those?
Yeah, I do. I'd say that there's been new interest in AVR, the lead that's been underappreciated over the decades. So ST elevation in AVR, I would think of it more like a sign of ischemia rather than acute injury. But we do specifically other things like right ventricular infarction. Sometimes we have to do special leads or right-sided leads to help diagnose right ventricular infarction. But usually when we're looking at some of these findings, like in lead AVR, they're usually in conjunction with more diffuse global ischemic changes in the ventricle, and it can be very hard to differentiate acute STEMI heart attack type things that need emergency intervention and just patients who have sick hearts and bad arteries who need medical management. So this is a gray zone right now in STEMI care where we see global ischemic type changes in the EKG, but not the classical criterion for STEMI. Do you press the button? Do you activate STEMI? Do you call in the team? Do you call in the interventionist? Or is he going to get upset when you call him because it doesn't meet criterion for STEMI? But it has been clearly shown that there are some dangerous subsets, anatomic subsets that can present with atypical types of EKGs that look ugly but don't clearly meet criterion for STEMI. And those patients usually have bad disease, they can be very sick, and they often may need emergency intervention from the team. So in those patients, sometimes it's good to take a look at them in the emergency room before we decide to go to lab to see if they're easily controlled. And sometimes there can be other things going on. They could have pneumonia, sepsis, anemia. They could be stressing the heart out and causing these global changes. And when you get their blood count back and you see their hematocrit's 12, or their fever's 103, there may be other issues that will determine whether or not those patients go to the lab.
So when we look at the essentially the muscle wall, and you have ischemic portion of tissue, how does that? I think they talk about the difference between injury and cell death in the muscle tissue, and is it a transmural kind of infarction, or can you explain a little bit about that?
So in the old days, we used to divide MIs. So we just look at MIs. We used to think of transmural, as you mentioned, and non-transmural. So if we have a segment of myocardium, and a transmural myocardial infarction means there's a through and through area of damage, whereas non-transmural, there might be a portion of the heart that's damaged. I like to think of, when I think about MI, I think it's helpful to think of more of a speckled or peppery type pattern. So as you start to interrupt the blood flow, either gradually or abruptly, you start to get injury to the heart muscle. So think of injury as happening like this. And if that vessel is completely occluded, completely closed off with no collateral or backup blood supply, then that quickly gets more and more dense to the point at where it becomes this. Sometimes you can have natural collateral blood flow can help. Sometimes a blockage may be kind of hanging on with a little clot in there. So if you have an artery with a plaque, a ruptured plaque and a thrombus, you can have a trickle of blood through there. And sometimes your medical therapy may shift how much blood can get through the artery to this location. So you can, the goal is to try to stop this in its tract before the density of this infarct gets too severe.
And that really points out the dynamic nature of what we're dealing with.
And we stopped using this terminology because we found that when you look at your EKG, we normally would say a Q wave indicates transmural damage, but we found that this does not always it's not always the case. So Q waves don't always reflect transmural, and by the same token, absence of Q waves doesn't necessarily mean non-transmural. So there can be, the terminology has been replaced with Q wave, non-Q wave, or STEMI and non-STEMI. So most of the data presentations break people down to STEMI and non-STEMI, and there's quite a bit of differences in how these present both electrocardiographically and in other fashions. But what we want to do is we want to preserve this heart muscle. So if you think of the heart muscle contracting, and when you interrupt blood flow, just like not having enough fuel, that muscle stops working. So hypokinesis is the word we use. Hypokinesis, akinesis, dyskinesis. So in a ventricle that's contracting, you may have just a sluggish area of hypokinesis. You could have an old heart attack could be a very thin portion of muscle that's scarred over, that's akinetic, or you can have a part of the muscle that bulges. I'm exaggerating here, but this could be an old area of damage that can be dyskinesis. So we look at the muscle function and we try to match up how the muscle's behaving, how the artery looks, and then also, when we're doing acute care, we're looking at the enzyme rise, so troponin. So when we're trying to decide, patients say, how bad is my heart attack? How bad is my heart attack? Well, it's important to link all these things. So you look at the EKG, and we kind of know bad EKGs, good EKGs. That's one factor. It's really important to see the echocardiogram to assess the heart muscle function. would say on that topic that it's also one moment in time when you do that initial echocardiogram, that often when we open arteries, restore the blood flow to that area of the heart, when you do the echocardiogram 6 weeks later, you might find that that muscle has returned to normal. So restoring blood flow can save heart muscle. But we look at the echo to assess heart muscle function, we look at the EKG to assess the severity of the infarct, and we look at the troponin. So normal troponin less than 0.04 is a super sensitive enzyme. So when muscle is damaged, it releases this enzyme into the bloodstream. We measure it. It's super sensitive, relatively fast, and usually in our lab, it stops at 50. Above 50, it just says greater than 50. But you get a sense of the heart attack if you have a troponin of 30 or 3 in a row that are 30, then you know you have a pretty bad heart attack. If you have a 2.1 troponin, you know it's relatively mild. So you can expect more recovery when you see a troponin that's low in an area of muscle that's not working. You may expect it may get better if the troponin's low, or if you quickly revascularize the patient. So I like to put all those together to try to tell a patient how bad the heart attack is. And sometimes we have to wait until we see them back in several weeks with a repeat echocardiogram to know how much recovery there's been.
When I bring you a patient, do you do any kind of quick assessment of wall function with ultrasound?
So typically, if I talk about the initial assessment, what we do, we usually do not have a troponin when we come in to see the patient. So those labs take a while, and we don't wait typically for a troponin measurement to come back. And we usually do not do echocardiograms in the emergency room. Although in our sicker patients who have cardiac arrest, who are complex, where we're concerned about maybe a COVID infection, sometimes a point-of-care ultrasound, the echo equipment, the ultrasound equipment they have in the emergency room, often we'll let them take a quick peek. And basically, you're looking to see what chambers are abnormal, or you can also, that ultrasound, sometimes it's important to see the pericardium, because sometimes we have people come in who have acute pericarditis or pericardial effusions. So the pericardium normally has just a minimal amount of fluid, enough to make the heart slip inside this sock around the heart. But in some pathologic conditions, you can have chronic or acute pericardial effusions, fluid around the heart. And that's something in a cardiac arrest patient would change how we handle things, because we might want to just stick a needle in there and drain that fluid off in order to help the patient.
Does that present differently on EKG?
It's important to differentiate acute pericarditis, from a STEMI. And there's a couple of clues that help us sort this out. But usually in STEMI, you want to look for reciprocal changes. So if you have ST elevation in the front of the heart, the anterior wall, you want to look at the bottom of the heart, and you should see ST depression. So reciprocal changes on the opposite side of the heart that's being injured. Acute pericarditis does not have reciprocal changes. So that's one thing. So when we think about an inferior STEMI, you look for high lateral ST depression. Anterior, we look for inferior ST depression. So each of these types of heart attacks present a little bit differently. But so reciprocal changes, really important concept to learn. It'd be great to see some examples along the way when you have them to show students what that looks like. So acute pericarditis is more diffuse across multiple leads without ST depression and reciprocal leads. The other finding first of all, I'll draw this normal EKG. So we talk about the PR segment. So this line between the atrium and the ventricular polarization. If you just think of the complex here being on a flat graph, think of that as your baseline. We know at ST elevation, we see this go up, we mentioned that. But with pericarditis, acute pericarditis, you often see what's called PR segment depression. And what that indicates is altered atrial repolarization. So that's kind of a mouthful. But whenever there's a complex conduction that's fired, there's also a recovery phase for that conduction. So the atrium fires, depolarizes, and then there's a recovery. And that recovery sometimes can be altered in pericarditis, the atrium being maybe more sensitive to picking this up than the ventricles, and you look for PR segment depression. So that's a subtle clue, and sometimes you can impress people by finding that and making that differentiation. So pericarditis, you think pleuritic chest pain, so take a deep breath, it hurts. Position, laying back worse, sitting up better. So that piece of history is really important. Usually it's a sharper pain, it varies with respiration, and then when you do an EKG and you see ST elevations diffuse without reciprocal changes, and then you can fine tune it. You can listen to the heart for a pericardial friction rub, kind of a noise that the heart makes when it's sliding in there. And that's a case where you might want to do an echocardiogram very early to identify whether or not there's infusion. You do not need to have an infusion to diagnose pericarditis, but you do need some criteria. You need symptoms, EKG, echo, these things. When you look at all those things together, you can make a diagnosis. And sometimes you may not hear a pericardial friction rub on first listen. In those patients, it's important to listen frequently, because in different positions, you sometimes hear pericardial rub. Make sure it's a quiet room, and have the patient sit up, lean forward, some things you can do to try to bring up rub. So that's a really important differentiation between stemming.
Well, we're talking about mimics. What about early repolarization?
So
we seem to see that a lot, and I think unfortunately it leads to some false activations on our end, not on your end.
So if we think, I draw with a heart again, kind of a normal heart, then I draw a heart that looks like this. If this is the left ventricle, and you look at this wall thickness, you can see a difference. And so when you have a hypertrophy or thickening of the heart, then you can get alteration and repolarization. So usually where this shows up is in the precordial leads. So if we look at, V1, V2, here, when you go V1, V2, V3, cordial leads, you'll see the R wave get taller. And with repolarization, what happens is you have a more prominent Q wave in this lead, sometimes R wave, depending on what lead you're in, but more prominent QRS voltage. And then you'll see ST elevation in the in these areas. So usually reciprocal changes, the ST elevation is in conjunction with a large QRS complex in the opposite direction. So if you had a tall R wave, you might see ST depression. So that's the altered repolarization. If you see a tall like a Q wave, your ST elevation might be in this lead. So always, when you're trying to assess that, you have some history of the patient has hypertension, but if you see voltage criterion, look at the voltage. If you see high voltage in the electrodes, and you see these changes, then you have to wonder about altered repolarization. And there are criteria in your EKG books that will tell you exactly what cutoffs there are for voltage and left ventricular hypertrophy. We often see this sometimes in sick people who may collapse with exercise. So when we think about, let's draw the normal ventricle here, is the aorta. So some conditions, and some people have asymmetric septal hypertrophy or hypertrophic cardiomyopathy. They may have a very large, thick septum. This shows up as voltage on the EKG, but you can see this can even pinch the the outflow of that blood through the aorta. And if those patients are volume depleted, say they've been out in hot sun, they're dehydrated, or if they're bleeding or something, or ill for other reasons, then the heart starts squeezing and you can get hypotension because of this obstruction that actually sucks in the mitral leaflet in what we call a Venturi effect, or like a shower effect. When you turn the shower and the shower curtain gets sucked in, this is what happens to the mitral valve in hypertrophic cardiomyopathy patients. In other conditions, like aortic stenosis, where you have a valve that doesn't open, you can also get hypertrophy. So that's another form. And these people can also have passing out spells if they don't get enough blood across their aortic valve. But so these conditions, hypertrophic cardiomyopathy, long-standing hypertension, aortic valve disease, or other major valve disease, can be associated with hypertrophy that shows up on an EKG with mimicry to stents.
Great. Okay, let's see.
Maybe can I make a suggestion?
Absolutely.
Maybe
go
talk
ahead.
about coronary atherosclerosis.
That was right on my list. Yep.
All right,
Yeah.
so-
What causes this? We've learned what it is. Now, what causes it?
I'm sorry, I'm going all over the place, but
No, this
just
is
follow
great.
where my nose leads me.
This is great.
So it's important to think about the cause of heart attacks. So because there's several different things to think about. So if we go back to looking at coronary anatomy, and if I draw a vessel in cross section, so normally you have, if you cut an artery like a sausage and you look at it, you're going to see these different layers, and so we'll call that the medius, the muscular layer of the artery, and inside that is the endothelium, or the cells that line the artery, and the blood flow in the middle. So kind of what goes wrong. So in people who develop atherosclerosis, and what we see is this, where there may be fatty buildup that starts pushing this intima inward and filling this up. So this can be an early atherosclerotic plaque, and this may change over time. Important when I think about heart attacks, I think some people like to think that this is a very gradual process where the arteries are gradually filling up and then eventually cause a heart attack. That's not usually the cause of a heart attack. So I like to think of it in a stepwise fashion. So the key concept is plaque rupture. I can't spell, sorry. So plaque rupture. So you can have a modest plaque. Say this is a 40% narrowing in an artery, but you can have erosion of this lining of this plaque that can cause the plaque to rupture. So remember, blood is flowing by, and you have this plaque, and now you have a plaque rupture. And I'll talk a little bit about why plaques rupture. And now the blood is able to see what's happening inside this plaque. It starts a cascade of cellular reactions. So we all know that we have these little platelets buzzing around in our blood system that become activated during times of crisis. I was talking about if the tigers, if you just got bit by a tiger, you may bleed to death. You have to stop the bleeding, and everything's adrenaline's all pumped up, and you're activating these platelets. And think of them now as being sticky, and they want to grab onto anything they can grab onto. So an activated platelet, this reaction happens in response to the blood elements being exposed to the inside of this fatty plaque. It starts a cascade of angry cellular changes, and clot starts forming. And now, if you had a clot here in this artery, and it never closed the artery, you wouldn't necessarily know it. You'd go about your business, this plaque would heal up, but now your artery's a little bit worse. And then if you get another plaque event here, rupture event, and you can start to see that in the stepwise fashion, arteries get progressively clogged. And then if you're one of the unfortunate people that has this event happen, but now you have an aggressive clot, it's filled up the artery and closed it off. Now you have poor blood flow downstream, and now you have an acute heart attack. So
now,
go
I'm
ahead.
sorry. Would a similar issue be, so I have hypertension, unusual pressure on the vessels, does that create injury to that intima, and then?
No, so hypotension,
Or hypertension.
hypertension. Yeah, so there are risk factors. First of all, there's risk factors for getting this plaque, and I saw it on your list to talk about. So our list of risk factors, we think about smoking, hypertension, big one, diabetes mellitus, either type 1 or type 2. We have hyperlipidemia or high cholesterol levels, either cholesterol, triglycerides, or hyperlipidemia. And we have family history of coronary disease. One might also add peripheral vascular disease. So if you have marker of other atherosclerotic vascular disease in your body, all these risk factors, 5 or 6, depending on how you want to list it, these contribute to the formation of plaque and are addressable. Clearly, some things you can change: smoking, hypertension, controlled diabetes, cholesterol. You can't change this. So there are these other risk factors that may lend themselves to this. So when we talk about triggers for the acute heart attack, certainly uncontrolled hypertension. Remember, the heart is beating. I like to think of this: the heart is beating, and the vessels. These vessels are moving with each heartbeat. So when you have these kind of sometimes tortuous vessels with a plaque here, sometimes the active more strain on that vessel, whether it's shear forces that come down at near a bend in an artery, or uncontrolled high blood pressure can cause this crack in the vessel that can lead to thrombus formation. So these factors can trigger this event. When we talk about, since you mentioned hypotension, so people have heart attacks because, say, they're short on volume, or they've taken too much medication. Some of these people may have underlying disease, and when they don't have enough blood pressure to get through that artery, they can show signs of a heart attack. So that would be more of a type 2 or demand-related heart attack. So we think of type 1 MIs, where you have a plaque rupture, an acute change in the blood vessels causing the MI. Think of type 2 myocardial infarctions, where there's an increased demand put on the patient for whatever reason, underlying illness, anemia.
I think of rapid AFib. Is that
rapid
same
AFib? Exactly.
Kind of thing?
So
Okay.
suddenly your heart rate's going 160. Normally you have normal arteries, but you've just outpaced the demand that you can't keep up. And so remember that coronaries fill during diastole. This is another important concept. So we think about the heart contracting, the systolic blood pressure, and we think about then the diastolic pressure. Remember, the coronaries fill during the relaxation phase of the heart. When you, if you start with a heart rhythm like this, and then suddenly you have atrial fib, what happens? Your diastolic filling phase has just shortened. Now there's a much shorter time for the blood to get down the artery between heartbeats. So treating these patients who may have chest pain, may start to usually more ST depression than ST elevation, but they can have a heart attack. It's really important to get the heart rate controlled, and you can quickly get that patient down. So that might be IV beta blocker, cardizem, diltiazem, emergency cardioversion, things done in the emergency room to try to take the strain off the heart.
I've always had that question of when I do have a tachycardic STEMI patient that I've activated and I bring to you, is that one of your first goals, is correct the rate before deciding whether to take them to cath?
Well, if they have ST elevation, usually they're going to go to the lab. Usually you're not going to, you make corrections, but they're probably going to go to the lab. So usually it's more ST depression or more non-specific changes along with pain that sounds like it could be heart attack pain. And so when you see just a fast heart rate, we want to, so fast heart rate, let's just talk about that for a second. think of all the things that can have cause fast heart rate. So there's the primary. You can talk about the primary rhythm disturbance that we just mentioned. So VT, AFib, SVT, these kind of conduction changes that really just require intervention in the heart rhythm. But you could think about the patient's volume status. So if they're hypovolemic, if they've either been on too much diuretics, or they're bleeding, or they have some other condition where they've lost the fluid volume, then the heart rate naturally would go up. So you would not want to take a hypovolemic patient and just give them medicine to slow the heart rate down, because then they could drop their blood pressure. So we kind of do an assessment of volume. So we look at neck veins. So get used to looking at neck veins as a quick, easy assessment to see whether or not, at least on the right side of the heart, the volume status is high or low. So flat neck veins and tachycardia, you have to wonder about a volume depletion. What if you had a ruptured abdominal aortic aneurysm? Veins are going to be low, heart rate's going to be fast. There are other things to think about.
What's the best way for a paramedic to assess neck veins?
So there's a couple of clues. So just think about body position. So I'll draw a little bit of a neck here. So you have your muscle, your sternocleidomastoid muscle here, and your clavicles here. So we're looking at the side of the neck. Sometimes it helps to shine some light on it to see a shadow of the neck vein. But we know that usually you can't tell too much when the patient is lying flat. So you want to, if you see the neck veins in the sitting up position or standing position, that's abnormal. Usually we want to tip them back at 30 to 45 degrees or so, and we can adjust the bed sometimes to see where that meniscus is, where the kind of the bulge of the neck vein ends. And then what you do is, if you think of, if this is the chest here, the heart here, we think of how many, we add 5 centimeters to account for the chest, the elevation usually between the chest wall and where the neck veins is. So you get 5 centimeters in that, and anything you measure above that gets added. So you can get a central venous pressure of 10 if you measure it 5 centimeters above the angle here. So that's a quick way, but I would look at the neck veins, make sure the lighting is proper, have the patient turn their head to the side, and then you can change your elevation a bit to try to see it. If the neck veins are full and you lay them flat, they're just going to feel full. You won't really know unless they're obviously bulging. And sometimes in real sick people, even when you sit them up, you can't see the neck vein meniscus, but if you look on the edge of their neck, you can see it rising and falling. So there are certain subtle ways that if you talk to Dr. Abraham, our heart failure director, he'd be big on this. And those are great clues, though. When you're trying to assess a patient, if you can do things non-tech and get some sense, patient volume, heart failure, no heart failure. When you combine edema, when you see pitting edema in the legs, you should be looking at the neck veins to see, is it just venous insufficiency, or is it because he's failing right heart's causing neck veins?
All
What
right.
else can I talk about?
Well, should we talk about an actual STEMI activation?
All right.
Getting you out of bed in the morning, or early morning. Okay, so, and Adrienne, maybe I'll bring you into this process as well. Give Dr. Wilson a little bit of break.
So Adrienne's pager goes off pretty much the same time mine goes off, almost more often, because she's covering every day all the STEMI. She's seeing everything all the time. She doesn't. But anyway, so EMS goes to see a patient with chest pain. They do their EKG. They see a typical STEMI on the EKG, and so that would be pre-activation. So they would, you would call the emergency room.
Pre-activation, what we call an activation.
And they trigger the activation to us. So when we have a call that's a clear-cut STEMI, say it's Wilson, or someone just walks into the emergency room and they have an EKG that's characteristic of STEMI, there's some differences in how we work our workflow. But basically what happens is the whole team gets activated. So the STEMI doctor gets called. The cath lab team members, usually 4 in our hospital, get activated. The CICU, or the intensive care, gets notified.
Transfer center
gets notified. So there's a whole network, and the goal here is not just to bring the doctor and the team in to treat the patient, which is really important, but also we have to think about the bed situation. Is there going to be a bed available for this patient? Do we have to move things? Do we have to consider alternative treatments, like moving the patient to another medical center? Even rare cases, we've even given lytic therapy if the cath lab teams are totally tied up and the patient, can't be moved efficiently and needs management. We can try to dissolve the clot, open up the artery. So we have a range of things that we do. In terms of activation and time frames, doctors should respond within 5 minutes.
5 minutes.
5 minutes is the time to call back. And then we expect the team to arrive
In less than 30 minutes.
less than 30. One day it used to be 20 minutes. The team members live farther away from the hospitals. It's kind of impossible for all of them. The people who live farther out nowadays will actually stay in the hospital when they're on call.
And it's the longest 30 minutes of your life.
Right.
Yeah, and so racing in, get in. So let's just talk about an emergency room case then. So I usually can get in quickly. I go right to the emergency room. I assess the patient quickly. I look at the tracings, talk to the doctor and the team there. Usually management will include patient may have been given nitroglycerin en route, and often the EMS will give aspirin, 324 of chewable aspirin en route. Or
they better always, unless they're bleeding. So
that's important to know, and it's important for our team to document that that's been done almost always by the EMS. We often will give a bolus of heparin to thin the blood, but we don't start a heparin infusion in most cases because it just adds extra time and baggage to carry the patient in the cath lab, and usually the bolus of heparin is enough to carry them through the time frame that we're talking about. So I look at the patient, I check their vital signs, I do a PAR-Q. So I explain the procedure, I get consent in the emergency room, either from the patient or a family member, close family member, if the patient can't easily communicate. And then we have that in place. So we wait for what we call green light in our center. And green light means that our cath lab is ready, all the team is there, the nursing staff is there, they have they're in the room. So even if they don't have all the packs opened up, whatever, they are there ready to receive the patient. So if I've gotten consent from the patient, I've eyeballed the patient, quick examination, and the green light comes on, we move the patient right to the cath lab and we prep them. Usually we prep their right wrist, we prep their right groin at the same time. 90% of the cases at our lab are done through the wrist. So radial hard cath. So we maybe before I jump into cath,
you said 90% or 90?
About 90% of the cases are done radial cath.
So from my point of view, do I need to worry about where I'm starting IVs?
Perfect question. Yeah.
Okay.
I would almost always avoid the right wrist area.
Okay.
So
fortunately, that's the other side of the patient when I'm sitting in the ambulance. So
now if you happen, now this is a high level for the more experienced people on the team. If you find out that the patient's had prior bypass surgery, think about protecting the left wrist, because if they have a mammary artery graft, we like to go through the left wrist to image the left mammary, which comes off the left subclavian. So we do make a difference, and our interventional recovery unit nurses know now which side to prep and what to look for. So if they're a bypass patient, we're going to be using the left arm and right groin. If they're non-bypass, it's usually right wrist, right groin. Groin is a backup in case we can't get up because of tortuous vessels or unusual anatomy, or if we need either support, mechanical support with a balloon pump, Impella, or if we need to put a temporary pacemaker in for especially inferior MIs, we want the right groin prepped and ready to go so we can quickly place a tube in the vein, thread up.
So radial has less complications. Is that why?
Yeah, the radial hard cath. This has been a huge life changer for us, and we started doing this in 2013. We kind of started to transition, and so I think like a mature forest, a mature STEMI program will have incorporated radial cath into their main workflow. The reason is because the lower bleeding risk. So if you're poking the femoral artery and you're moving needles around there, or the patient's moving, or you get a bad stick in a bad location, or you can't close the vessel properly, there's an increased risk of bleeding, retroperitoneal bleeding, pseudoaneurysm, pulmonary embolus due to accidentally compressing the vein too much or causing trauma to the vein that causes a clot that goes to the heart. So we see more complications when we use the femoral approach. The nice thing about radial is when we're done, we remove the tube, we put a wristband on that has an air cushion that presses on the artery. We control the number of cc's of air, and that's very comfortable for the patient. They can get up and go to the bathroom shortly after the procedure. They have no risk of retroperitoneal hemorrhage from a catheter position. They're much more comfortable with that, and so it eases their way forward.
Great. Anything else that we can do on our end preparing the patient for you? Aspirin, serial EKGs, get the right location for an IV. What else? Is there anything else we could do?
Take off.
Yeah.
Close off is always
Close
helpful.
off is helpful.
ER
Yeah.
usually handles most of that probably. Sometimes the cath lab hates to get a patient to the lab when they still have their pants and shoes and socks on and all that stuff.
Yeah.
But maybe, Adrienne, I don't know if you want to talk about any of the initial workflow, because there's some differentiation between transfer STEMIs, field STEMIs, walk-ins. Do you want to say anything about them?
Well, it's nice. It's nice that they send a LifeNet in. That's one of the big things that I like, because it helps. The thing about that is it alerts us quicker, and then the physician can actually see it. So if it's not a STEMI or it's questionable, we can send it to the interventionist. They can look at it and they can determine whether or not we're going to go to the cath lab. So that's one thing about the EMS.
And they can look at that from
They can look
at
it
home in
from
bed
yeah,
on
home
their
in bed.
phone.
Yes.
Okay.
And the other thing is then they can also send back a comment to see them in the ED first, and then they'll look at it, do another tracing, because things change. And then as far as walk-ins and EMS are basically the same, because the process in the emergency department is pretty much the same. EKG, call the interventionist. They get to look and say yes or no.
Mm-hmm.
Since we've started doing that process, we have decreased our cancellations, which is a big thing, because you don't want to bring 4 people in at 2 o'clock in the morning whenever you have EKG that is not a STEMI. So, and then as far as transfers go, you guys do a lot of transfers from some of the hospitals around here, and so we've now changed that. When I first took this position, we had a hotline in the CICU, which was the charge nurse, and then they turned around and paged the physician, and then there was a lot of in between. Now it goes right to the transfer center. They can talk to the interventionist, they can see the EKGs, they can make that determination, and then the transfer center now calls PBX and we activate the team. We have a system as far as like close hospitals under 30 minutes, like Kaiser and Newburgh and those places on the west side. East side is Milwaukee and Willamette Falls. And if it's under 30 minutes, they activate right away. Your coastal hospitals take a little bit longer, whether they're life flight or not, and so they get a lot of the thrombolytics.
And you get some of our sister company, Medics, over in Columbia County.
Yes.
When LifeFlight can't fly,
When they can't fly,
they're going by ground.
Right.
And
So they give the thrombolytics. A lot of your coastal hospitals would give thrombolytics. So once they arrive, if they are pain-free, they make that determination whether or not we go to the cath lab at that point.
Mm-hmm.
Because you don't want to really cath somebody at 2 or 3 o'clock in the morning when you don't have to.
Mm-hmm.
And but it all kind of depends on some of the physicians, I think, don't really necessarily want to cath somebody after having thrombolytics.
Right.
But if they're still having pain, they will. It doesn't make any difference what time that is.
Gotcha.
So.
All right.
Let me talk. I was just going to talk about a little bit about the actual intervention and some other unusual causes of heart attack. So I'll just mention these in passing because not everybody has a classic appearance like a high-risk patient with hypertension, diabetes, and high cholesterol. We do have some cases we've talked about in our STEMI meetings quite a bit. SCAD stands for spontaneous coronary artery dissection. So when you see, say, a 41-year-old female who exercises regularly and has no risk factors for coronary artery disease, but presents with classical chest pain and EKG changes, don't immediately blow it off and say she's got fibromyalgia or she doesn't have risk factors, she couldn't possibly have a heart attack. because we've seen these patients can have spontaneous kind of cracks in their blood vessels, so there can be a little split in the lining, and there's some longer discussion one can have about this, but basically get a hematoma under the blood vessel that pushes the artery shut, so it has a kind of a smooth appearance on the angiogram. Sometimes it's near a tortuous, bendy segment, and I've seen this, 10% of these occur in men. I've seen it with heavy weightlifters, people doing heavy trench digging. I've seen some of these events in men that can have every other feature heart attack, but the cause is a split in a relatively normal artery as opposed to an atherosclerotic plaque. So that's one thing to keep in mind. We see more and more of this kind of stuff. The other thing is embolic. If you see a patient who's in atrial fibrillation, say they've not been on warfarin or not taking their warfarin, so ask about blood thinners. It's something that you can do on your end.
Okay.
This patient's been taking warfarin, blah, 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 Eliquis, Xarelto, some of these drugs that if they haven't been in their atrial fibrillation, they can simply have just thrown down a clot from their atrial appendage. They get an atrial appendage clot, it breaks loose. The first stop when the blood is emptying from the heart is the coronary arteries. So we often think about stroke from clots, embolic events, because the head vessels come off early on, but also people can throw a clot down the artery. So sometimes when I see otherwise normal arteries, and I see an artery that gets down to a kind of a branch point like this, and I see an occlusion right there with otherwise normal looking vessel in a patient with atrial fibrillation, 9 times out of 10 I'm going to think that's an embolic event from a patient in atrial fib who has not had anticoagulation. People with prior graft disease also think about an acute graft closure, which most people would think about when they come in. But graft closure, especially vein grafts, close more than arterial grafts, so that's a problem. But getting to the procedure of what we do, so we do the angiogram, and we have special catheters that fit these coronary arteries, and so this is called a guide catheter. If we found this LAD artery closure right here, we only see this much of the artery, right? We just see a stump where the vessel is. So it might be worth mentioning the TIMI flow score, 1, 2, 3. So we use this TIMI score to judge our heart attacks. If a TIMI 0 would be no blood getting through. You just see the stump. TIMI 1, you see a trickle of blood flow getting through. TIMI 2, you see a delay in the blood flow to the end of the artery compared to another vessel that has no blockage. So you look at the blood flow as you inject in the non-infarct artery, and if the vessel fills, at some point it eventually fills, but in a slower fashion, that's TIMI 2. TIMI 3 is normal blood flow, brisk blood flow from the start to the finish, and all vessels looking similar. So this is our goal after we treat the patient. What we would do in this case is we thread a wire. So we have a guide catheter. We thread a steerable wire down the vessel, and then we use we do one or two things. Sometimes we just take a balloon. The balloons are just mount on this wire. You can barely see them when they're not inflated, and then we inflate them with the inflation device, and they stretch this artery and open it up.
So that wire is able to push through that clot?
Yeah, we can steer wires. We have wires at various levels of stiffness or lubricity, coated wires, stiff wires. They measure these wires in terms of grams of force, but in a typical heart attack, it doesn't take much but a simple wire to get through there, and then we have to make a decision. So one decision is just go ahead and start using a balloon to inflate it to get flow restored immediately. But in some patients, when we see a lot of clot, we will do what's called a manual thrombectomy. So we have a hollow tube, just think of it as a hollow tube. We thread over this wire, it has a side port for the wire, but we thread that down right to here, and we start aspirating. We start pulling back with a syringe and different devices we have, but we slowly move that device through the clot, and we just vacuum it out and suck it out. We can spit it into a filter, we can see the clot right then and there. So often that will we start flow. And when we look at door to balloon time, it's more door to device time. So if we use a manual thrombectomy, that's our device time that counts as door to balloon time.
Is there any risk of breaking up the clot and causing little micro heart attacks?
Well, absolutely. That's why we sometimes use the thrombectomy to aspirate and remove the clot as much as possible, because if you have a very clotted vessel when you balloon it, you can end up with this kind of pruned off tree approach where you open the artery, but all the little branches are covered with thrombus. And so that patient will have a more extensive heart attack. And there's a lot of data in this regard. Some of it's mixed data. So some data says there's no benefit to mechanical thrombectomy or manual thrombectomy. Other data suggest that there is some benefit. So I think each doctor is on a case-by-case basis. It's not a routine treatment. It's only when we see a more bulky thrombus, and we have to be especially careful, because when you're sucking back thrombus, if you get it to this point and it breaks loose, it can cause a stroke. So the fear of thrombectomy is stroke, and so there's certain precautions we take to make that happen. Once we balloon this vessel and kind of get it open, it still looks pretty shaggy most times. We go ahead and bring our stent down. So the wire's down. We go ahead and bring the stent down. It's like a balloon, but it has a stent mounted on top of it. So when we inflate the balloon, the stent pops open. It pushes the artery open, and now it locks into place. So these stents stay open. The balloon gets removed. The wire can get removed. And we shoot for 0% residual blockage after that.
And then when I read the feedback reports, I often see drug-eluting stents.
Yeah.
Yes.
So
DES, drug-eluting stents, this is a standard of care. In the old days, we used to differentiate, like a lot of heart attack patients would get bare metal stents because they were worried about clotting. And that's gone now. So bare metal stents, forget about them. We're not using them anymore. All the stents we use are drug-coated stents. In the case, our most common drug coating is everolimus. That's the best drug right now based on data.
And the other thing that you might see is crossing the lesion, and there might be difficulty with that, and so that's where they have problems getting across that lesion.
Yeah, there can be some real tough cases. So in a vessel that has a dissection, if it's real shaggy, if it's calcified, if it's bendy, if it has a branch near it, sometimes a blockage. You may have an artery like this. It's closed here, but it may be that you're coming this way and you have to go around this corner and down. So there are some anatomic variants. Since I mentioned graft closure, I'd also say that we do not like to mess with old vein grafts. Old vein grafts, so if you had a vein graft down to here and that graft closed, usually they get full of clot, and when you try to open them up, a lot of this debris, unlike natural vessels where you can control this phenomenon, if you have a tube full of debris and clot here, that it can just fall down the artery and close up everything. So that's called no reflow phenomenon. But that's we really slow down when we see that there's a vein graft closure. Sometimes what we'll do is try to reopen the natural vessel and not mess with the graft, or just if we can, in some cases, we can just direct stent, meaning we go in, put our stent right on there a little longer, and just hit it once, push it out of the way, and try to minimize any complications.
Gotcha. Wow. So from
I've gotten
point of
deep down,
procedure, I mean, this is amazing. This is great.
Even I'm learning.
And how long does a typical procedure last? And then talk a little bit about the recovery. Are they going home next day, 2 days from now? I know it's gotten...
usually the procedures last about an hour.
Okay.
So most straightforward STEMIs, there's a lot of it's setup time. So time getting set up, getting the patient prepped, getting the tubes in, getting the angiogram. So those things, the actual procedure is very quick usually.
Usually about 15 minutes or less. That's how long it takes them to get the vessel opened. Once they get all the prep done and all that and everything else, that's your actual time.
Yeah, so 15 minutes about usually just to get the first balloon inflation and get flow down there.
Right.
And people who have bypass grafts we have to look for, that's more complicated. But then when we're done, so in terms of where the patient goes, in the old days they all go to the coronary care unit, but now there's a big push. We try to get patients to a standard telemetry unit after a heart attack. So most of these patients don't need critical care. And so while we're working, we're opening the vessel, I'm turning to the nurse and say, okay, let's get a telebed. So even though they may have come in and had a reserved CCU bed, or they're planning on it, if I see the patient's pain is settling down, the artery's open, they're not having rhythm problems, their blood pressure's good, they're not on pressors, if all those criteria are met, we're going to get that patient to a telemetry bed. So as I'm working, I'm talking to the nurse, telling them to get the telebed ready. And then we put the wristband on, off they go up to tele, and those patients, usually they're going to get at least a full day in the hospital. So if they come in at 7 p.m. On Monday, they're going to be there all day Tuesday, and then maybe go home Wednesday. Because the other things we think about, we want to make sure the blood pressure is treated, they're on good medications. We want to assess their ventricle with echo. If they have a bad ventricle, they might need titration of medications. They might need 4 or 5 different medications all together. And we want to make sure the patient's on stable regimen, up and around, feeling good, not having rhythm problems, and then they get to move.
So on the other end, you do your procedure, they don't recover very well. They run into cardiogenic shock. You're in the middle of procedure and decide a balloon pump needs, or impella needs to be replaced.
I'll talk about a case. I'll talk about a case that I had recently. Okay, so the bad stuff.
Actually, I was going to ask, because is there a specific thing on the EKG that tells you you're going to have a bad case? I mean, because I think
More sense of the EKG, it's more looking at the patient if their blood pressure's low. So if you see if they're tachycardic, low blood pressure, so cool, clammy, peripherally, heart attack, that means underperfused, bad ventricle. There are signs. So if you see someone who's really, they have a bad EKG, but they're feeling bad, their blood pressure's soft, and they're a little clammy, we worry about those. If it's anterior more than inferior, usually, we worry about the state of the ventricle. So, and we do not usually, we infer this without looking at the ventricle. Of course, if we had an echo on everybody, we know what their ejection fraction is, how bad the ventricle is, but usually that's something we find later. And we don't like to squirt dye into a ventricle during the acute setting because it's a stress to the heart and it could tip them over and have trouble. But so I had a patient recently, cardiogenic shock, yeah, and he had, let's see, I'll draw his anatomy of it. So we knew that he had his LAD artery was closed, and I believe he had what's called a non-dominant right, a small right artery, and he had a blockage that involved this spot right here. So his whole source of circulation was in these branches, and he was not getting enough help from the right, and the LAD wasn't helping him either. And so I can't remember if he had a graft on there, but in any case, he was really suffering. So when I just took a couple of pictures, his blood pressure systolic was 65.
Ooh.
So he may have come in the room at 90, 95, but the strain of 2 angiogram pictures to lay out his anatomy with this not showing much, he was 65. So what we quickly did is we prepared his groin, so we used an impella. So an impella is a big tube, so if you're down here on the legs, and this is the aorta, if you're too small, femoral artery here, so we'll put a sheath in here. I'll take a quick peek at this to make sure it's big enough and not too curly. There's a 14 French tube for an impella, so it's a big tube, like this. So that comes up the aorta, and this crosses the aortic valve and has a pigtail here. So a curly tail here. This is the left ventricle. It has ports that suck in blood, and then it spits out the blood here. So this is an axial flow pump. It's hooked up to a device, and it can move 3.5 liters of blood per minute. So when you have 3.5 liters of blood moving in, the heart can stop.
You've got steady
The
flow.
patient can be talking to me, but they'd be dead without it. So we now, for cardiogenic shock, we usually think about using impella. It's better than a balloon pump. Balloon pumps are inferior in many ways. And this allowed me time, once I had him there, I had good blood flow. It cooled things down. His mean pressure was higher from the pump. I was able to go ahead and put a kind of a complex stent procedure here where I did double stents from the left main into these 2 branches, restored blood flow here, and he perked up.
How do you just decide which branch to tackle first?
Well, we quickly put wires in both. We take balloons, balloon here, balloon there, whichever order, get blood flow. So once you have it, now you have it open, then it's a matter of placing the stents, which is a little trickier because you have overlapping metal, and you have to make sure you don't close one branch when you're doing the other. So that's a kind of a detail we deal with a lot. But we ended up with a beautiful angiographic result here. The patient improved. He had Impella for a couple of days. We weaned it off, and he got changed. His medicines were changed, and he was sent home.
Yeah.
Great. Wow.
So there
Awesome
you go.
example. Yes.
And if they don't do better, then we call Dr. Abraham or his
And he
team,
gets-
Yeah.
and they might get a left ventricular assist device. They might move the Impella can be moved to an axillary location so the patient can be moved. They could be considered for urgent transplant, heart transplant. Sometimes it's a bridge to surgery.
Okay. I think we covered everything.
I think so.
More than I expected. This has been great.
All right.
Thank you very much, Dr. Wilson. Thank you, Adrienne, as always. Continue to do the awesome work.